So our objectives, want to understand recent progress that's been made towards screening, and I think that's a very exciting part of the talk. Chemotherapy, and then also immunotherapy, which you hear in the news a lot, and we'll try and figure out what does that really mean. And then we'll talk a little bit about personalized cancer therapy, although Dr. Markman tomorrow will really go into that in detail. I think with this talk, for the part about screening, I think that's some exciting new data that are going to be presented. They were just presented in March at our annual society meeting. The immunotherapy part is also exciting, and then I'm going to lose you guys in the middle on chemotherapy, and I get that. So I'll try to point out the highlights of what's relevant, but the rest of it, if you gloss over and need to send a text message, that's your time. So, all right. So my one disclosure, I am a PI for a Merck-sponsored trial at CTCA in immunotherapy, but I don't get any other compensation for that, but I do have that trial open. My biggest conflict, as I have said many times in the past, is with my wife, who has a shoe and handbag problem. So a couple pre-test questions. FDA recently approved PARP inhibitors for which group of patients? HER2 positive recurrent disease, platinum-resistant recurrent ovarian cancer, women with recurrent cancer and a BRCA mutation, women with recurrent cancer and an intact BRCA gene. And then, which patients with high-grade ovarian cancer should be referred for genetic consultation? Patients with the first-degree relative with breast ovarian cancer, patients who are age 50 or less at diagnosis, all patients regardless of age, or patients diagnosed with early-stage disease. And then final question, 68-year-old presents with a 6-centimeter mass. What are the most appropriate tests to order as part of a referral? CA-125 and ultrasound, pelvic MRI with and without contrast, PET scan, or IR consult for tissue biopsy. So initially, when I would give a talk on ovarian cancer and I would review data that indicates screening decreases mortality or improves outcomes, it would be crickets and tumbleweeds because we really had no data that showed this. There was the PLCO study, and that actually showed probably more harm with intervention than any benefit, and that was the largest study done in the United States. There have been other studies done from University of Kentucky, and again, no differences in patients' outcome. When we talk about a screening test, it's always good to think about what's the job of that test. It has to be sensitive as well as specific, but there's a trade-off with those two. And then based upon the sensitivity and the specificity as well as the prevalence of the disease in the population, that determines positive and negative predictive values to help us identify who's really at risk. It has to have a reasonable cost. Patients have to agree to it. It has to be a reliable test, something that's reproducible at every center. And at the end of the day, why are we screening? To decrease mortality from the disease. And that's been the issue with ovarian cancer. We've not really been able to successfully demonstrate that. The study here that I'm reviewing was published in was done in the United Kingdom. You could see that they had over 200,000 women, and they were randomized into 3 arms here. One was a multimodal screening group of CA-125 using the risk of ovarian cancer algorithm plus ultrasound. Another was an ultrasound alone group, and then finally a control arm. Primary endpoint, ovarian cancer mortality, and this study completed its accrual in 2011. I'm going to focus on just the multimodal screening since that's the more pertinent part for this. But essentially the risk of ovarian cancer algorithm is a Bayesian algorithm that looks at an individual CA-125 and compares that profile to patterns with women of ovarian cancer as well as healthy women. And then you can kind of see here with the 2 boxes whether the serial measurements for a cancer patient in the top left where there's a significant rise up versus the stability that's seen in patients who do not have the disease. And then for the multimodal patients, they started with an annual ultrasound screen and CA-125. Normal went into the annual screening. If they were elevated risk, they would have a level 2 ultrasound with an additional CA-125. And if that remained abnormal, that would lead to a clinical assessment with either surgery or deemed to be a potential false positive. And then if they were indeterminate, they followed the CA-125 level, and that's where the repeated levels of the CA-125 would be helpful for identifying women at risk. So there were over 300,000 annual screens done, and ended up with 736 surgeries in this arm, so 0.2% of the population. So overall, a low number of surgeries, which is in general a good sign for this. Compliance was pretty good, 81% for the patients, and they had excellent follow-up for what happened for these patients in terms of death for 98.9%. So that's fairly remarkable, but that's also healthcare in the United Kingdom. In terms of primary peritoneal and ovarian cancers that were detected, both in the multimodal group and in the screening group, what you'll see there is that based upon the size of the cohorts, they were roughly similar in both groups. So, it's not as if one group, the multimodal screening group, had more or less that would influence how the data come out. And one of the keys to this study that I think is very exciting is that if you look at the invasive cases of ovarian cancer, they were more likely in the multimodal screening group to be early stage, and they were more likely to have low volume disease. Those things, for me as a GYN oncologist and as a surgeon, are very critical because the stage migration for ovarian cancer is going to, I believe, lead to better survival. When patients walk in the door, 75% are stage 3 or 4. There's nothing I can do about their stage as we sit here today, and that's why ovarian cancer is such a fatal disease. And on the front line, it's much tougher in the sense that you're explaining to the patient, why aren't you screening me? Why are you not doing a CA-125 or an ultrasound or some type of test? Because you're screening with mammograms, we're screening with colonoscopies. There's all sorts of screening we do, but not for ovarian cancer. And so that's a very difficult conversation. And it's something that I explain to the patients that, there is no screening that exists today that's been shown to improve outcomes. So we are where we are. But with this study, we started to see stage migration. And a stage 1 cancer and a stage 2 cancer is much easier to treat, and I'm going to have a much better chance for cure for that patient. The problem for those advanced stage cancers, even with a very successful surgery where we can remove all the tumor grossly and treat with chemotherapy, the majority recur, and that's where it becomes fatal. The other factor is low volume disease. It's much easier to do an operation on someone who has small volume disease compared to large tumors that require a full thickness diaphragm resection or a splenic resection or a splenectomy or something like that. So that's, for me, is very exciting to see stage migration as well as volume of disease decrease for this cohort with multimodal screening. Harms, there were some with regards to pain, hematoma, fainting, cystitis, other 8.6 per 100,000 screens. Missed ovarian cancers within a year of diagnosis was 16%, so there's definitely room for improvement there. And then what was determined unnecessary surgery where the results were benign, 14 out of the 10,000. But if we look at, interestingly, the major complications in the above, only 3.1%, and that's very reassuring in the sense that when the PLCO study came out a few years ago, up to 15% of patients who underwent surgery had some type of complication. So either there are much better surgeons in the United Kingdom or surgical techniques are improving. But either way, I think that's also encouraging for the women who do end up undergoing an invasive procedure without a diagnosis of cancer at the end of the day, that the risk of harm is overall low. In terms of looking at Cox proportional hazards model, in terms of looking for a reduction in mortality, and this is the primary endpoint, it's not been reached here. You'll see the blue line are the controls, red line's multimodal, and you can see the curves are separating, but it's not statistically significant at this point in time. So what do we do when we have a study and we analyze the data and we don't get the results we're quite hoping for? More statistical tricks. So if you use a different test, weighted log rank test, which is an alternative approach for what's determined a late effect, meaning we're not necessarily going to see the impact of the screening in the time frame of the period. It's specifically used for late mortality effects, and this was actually the statistical test used in the PLCO study and in other studies for screening and prevention programs, such as the Women's Health Initiative. So if we actually use that statistical test, you'll actually see a significant difference here in the curves. And I take that as encouraging in terms of multimodal screening appears. And I use the word appears, deliberately to have benefit for patients. I think that summing it up, there is a significant reduction in stage and in disease volume for the multimodal patients, which is where I focused, there was not a significant benefit in the women who just had ultrasound. And so there was no evidence that ultrasound screening had any impact on mortality from ovarian cancer. Multimodal screening may lead to mortality reduction, but it cannot be definitive, as reduction was not significant on the Cox model, but was on a post hoc weighted log rank test. So there's sort of a glimmer of hope there. I think that what we need is sort of further follow-up to really see if that's true. And with these screening studies where there can be a lag, that may become evident with time. And as we know, screening for ovarian cancer in any of the studies has been shown with associated with unnecessary surgery for some, but in this case, it seemed to be within acceptable limits for the patients. Cost effectiveness results are pending at this time. But this is really the first study that gives us a glimmer of hope that we may be on the right track for identifying a screening program for ovarian cancer. So I take that as very encouraging. One of the challenges for screening for ovarian cancer is up until 5-6 years ago, we really didn't know what the precursor lesion was. And so by the time an ultrasound would detect something, most women in those screening studies were advanced stage anyway, so we weren't moving that needle. We now know that part of the precursor lesion may be coming from the fimbriated end of the fallopian tube, and that's where the incorporation of the CA-125 using the AROC algorithm may be also helping us detect these patients at an earlier stage and with a lower volume of disease. So that's probably, of the data that I present today, probably sort of the most exciting that I can present to a group here who, deals with this disease, on the front line in that circumstance. We're still a ways before this is going to be a standard screening process, but I think that we're getting there, and I think that that's an encouraging fact for us. All right, so we'll switch gears for a minute and talk about chemotherapy. Purposely put in there a picture of pills since many of our agents are now oral these days, but it's also important to remember that oral chemotherapy is still chemotherapy and can have significant side effects for our patients. ASCO, American Society of Clinical Oncology, and we have tons of acronyms in medicine, and in oncology we're no exception with all of our different acronyms. So ASCO is American Society for Clinical Oncology. There's also a CCP, NAACP, NSQIP, the CDC, so there's 101 acronyms, and I apologize, I'm going to use a few right now, but I want to talk about ASCO in terms of when we talk about chemotherapy and we talk about sort of how we want to proceed in treating patients, making sure that we're adhering to the highest standards as possible. So COPI, another acronym for you, is the Quality Oncology Practice Initiative that's done through ASCO, that we've been a part of at CTCA and that we've been a part of in GYN Oncology through the Society of Gynecologic Oncology. The goal is its quality assessment and improvement, sort of for continuous self-examination. Lord Kelvin here sort of said, when you can measure what you are speaking about and express it in numbers, you know something about it. But when you cannot measure it, when you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind. So it's really about quantifying our outcomes. It's also about quantifying our practice patterns and what we do. And I think it's important to mention this when we talk about chemotherapy, because chemotherapy is definitely harmful to our patients. There's a lot of collateral damage that occurs with cancer care. And we want to make sure that we're providing the patients adequate support during the process of that and that we're providing them the best care possible. So SGO with the Society of Gynecologic Oncology has its own for ovarian cancer related to surgical debulking, and these are low-lying fruit for anyone to accomplish, I will say. Complete staging, intraperitoneal chemotherapy, which I'm going to talk a little bit more about being offered, platinum and taxane starting 6 weeks post-op, VTE prophylaxis after surgery, and stopping your antibiotics. So these are all pretty easy initiatives for a gynecologic oncologist to achieve, except potentially for intraperitoneal chemotherapy. COPI and CTCA, so CTCA has worked very hard to become a COPI certified center in the process, and you learn about all the different sort of quality indicators that go into what are the best medical oncology practices and how do we get better. And so that's something we constantly work on and refine when we talk about our chemotherapy patients. But getting certification was definitely a big accomplishment. And I want to talk about sort of some of the chemotherapy of ovarian cancer and how that relates. The picture here, the little diagram, kind of shows the difference between intravenous and intraperitoneal chemotherapy. And what you can see for cisplatin is you get about a 20-fold higher dose of the drug where the cancer is when you give it in the abdomen. If you give Taxol intra-abdominal, you get about a 1,000-fold difference, higher concentration of the dose. So there's a definite biologic plausibility to giving chemotherapy intraperitoneal for patients with ovarian cancer, which is essentially a peritoneal disease process. There's been multiple studies that have been done looking at this. The most recent, published in 2006, compared IV chemotherapy versus an intraperitoneal regimen. And you could see that bottom regimen, they were getting more therapy, which may also lead to why did it work better. But they also got much more toxicity along the way. If you look at the IP chemotherapy patients, more GI toxicity, neurologic with neuropathy, fatigue, metabolic, pain, and renal dysfunction. And, if you think about things, neurologic, one of my patients was a dental hygienist. I had to be very careful about giving her IP therapy because if she can't use her hands to pick up her instruments after she's treated and in remission, I'm not doing her any favor. So we sort of have to realize there is an added toxicity with this therapy, and there also is an added hematologic toxicity as well. But one of the most exciting things about this study was that it led to a 16-month plus survival advantage and an improvement in the progression-free survival. And, I think for any other study, if this was intravenous, drug A to drug B, and they were both given the exact same way, the exact same route, everyone would give the superior drug. But the problem is that's not occurring for ovarian cancer. This is just a meta-analysis of the different studies that have been done comparing intravenous to intraperitoneal regimens, and we could see, even in the meta-analysis, they favor the intraperitoneal chemotherapy for overall survival. And in a disease where they walk in our door advanced stage, we can often achieve a remission, but they're going to recur. Anything we can do to move that survival needle to make this more of a chronic disease process, I believe, is beneficial and worth working to do. Because of these studies, because of that meta-analysis, in 2006, the NCI put out guidelines saying that, even though it's toxic, it's inconvenient, it's more work for patient and even clinician, it's justified by the improved survival. And then what we need to work on is the tolerability and the toxicities, but it's the most effective means of treating cancer today. So I thought this was interesting because you go back and look in the newspaper clippings, which is where I get most of my medical information. Wall Street Journal and New York Times will have it before we will sometimes because the stock price changes for the pharma company. You look back, it's a great quote where in 2006, Chief of Gyn Oncology at Memorial Sloan Kettering says, "It's really the best news we've had in some time." And, advanced ovarian cancer is a bad disease, not the most insightful comment, but, many patients don't do well. When you have a study that shows a 16-month prolongation of median survival, it's a big deal. And Dr. Bearcat was absolutely right at that time. Dr. Markman, who was then at MD Anderson, now at CTCA with us, talked about, yes, it's going to require some training, but, he thought that, we'd be better off sending patients to experts in therapy was sort of his summation. Well, we then go forward to a study just done last year that looked at, in NCCN centers, who's getting intraperitoneal chemotherapy and how much are they giving. And what you can see there is in 2003, 4, 5, most of the patients are getting IV therapy, which is the blue. In 2006, you start to see some IP therapy come in, both as the study regimen, that's the yellow bars, as well as sort of modified off-trial regimens or some other patients in clinical trials. But there's sort of a quick ramp up, 2006, 2007, then it starts to dwindle, and it's decreased, significantly. And so this is a regimen, shown to have a 16-month survival advantage. And there's been a lot of different criticisms as to why it's not been adopted widely. So we go to New York Times now, 2015, and we have a direct quote from Dr. Morkman. "It's unfortunate, but it's the real world." And I think, the word tragic would be fair, is a harsh indictment of us as gynecologic oncologists and as cancer practitioners not getting this therapy to our patients. Clearly I showed you toxicity data, and the toxicity are real and they are significant. And I think that's the easy answer, to say it's toxicity and patients don't want that. I do believe that there are other factors that come into it. One is it's physicians having adequate training, physicians willing to do the work, because it does require more work, more time spent with the patient. And then the other is that unlike, if you watch TV, you'll see drugs now for immunotherapy. You'll see drug ads for Neulasta. You'll see all sorts of oncologic drugs being advertised. No one advertises this because there's no drug that goes with it. There's no device that goes with it. So there's no industry. There's no one at our doors saying, well, you know, they're doing this down the street, so you better start doing it too. You know, this center's doing it. If you want to keep up, you better start. There's no pressure from industry to do it. So I think, you know, that's unfortunately a real-world influence that's not there, and in this case, it's probably detrimental because it's a therapy that really can improve survivals. So, you know, intraperitoneal chemotherapy is a, yes, toxic, but also a life-extending and potentially life-saving regimen for some of our patients. So it's something that I am a strong advocate of for all of my patients with ovarian cancer, but it definitely takes time, it takes effort. But you could see that even in the NCCN centers, it's not widely adopted or widely used. If we talk about recurrent ovarian cancer, and we see a lot of patients with recurrent disease at our center, you know, this is where we also have to be careful about our goals of treatment, because our goal is to prolong survival, but I have no proof that I can actually do that. We want to delay time to progression. We want to control disease-related symptoms, minimize our treatment symptoms, and maintain or improve quality of life. And that last one's very important. You know, as someone who does hospice and palliative care, if I give my patients a regimen with recurrent disease, so I'm not talking about cure anymore, and I make them sick, I make them debilitated, so they miss a communion, they miss a wedding anniversary because they can't get out of bed, they miss a birthday party, that's a big deal for those patients in my mind. So we typically divide those patients in the recurrent setting into who's platinum sensitive and who's platinum resistant. The platinum sensitive patients, you know, in general are those who've had 6 months since they've achieved their remission, but it's obviously a continuum, because the longer a patient has her first remission, the better her survival, the better her chance of success with her subsequent treatment. And so that's why a therapy like intraperitoneal chemotherapy, which improves the progression-free survival, is a significant treatment for our patients. And if they are platinum sensitive, sometimes these patients have second surgeries, and then treatment afterwards is usually chemotherapy based. But I think this is an important study to point out, not because I expect you guys to really take home the regimens. That's, you know, I apologize, boring. But I do want you to realize that, you know, some of the work that we're doing is not only looking at, okay, we have recurrent disease, can we prolong the progression-free survival? And if we look at sort of a platinum regimen with 1 versus carbo and 1 versus Doxil, you can see, you know, that the hazard ratio for progression favored the blue arm there, you know, barely. But you can also see that we actually had an improvement in toxicity profile. So something like this is actually very exciting, not because there's a slight improvement in our progression, but because our toxicities are so much less. And again, in the recurrent setting, if they're not having alopecia, that could be a very big deal for patients. Neuropathy, you know, allergic reactions, arthralgias, myalgias, all those side effects which keep people in bed, prevent them from doing things, if we can mitigate that, we're really benefiting our patients. And that's where, sort of with our COPI, our quality outcomes practice, it's really important to make sure we're trying to do this as best we can. When we talk about platinum-sensitive patients, you know, we consider surgery, retreatment with platinum is standard, and if you do a doublet, platinum plus another drug, it improves response rate and progression-free survival, possibly overall, but really it's just progression-free. And we still don't know yet where targeted agents fit into all of this. Platinum-resistant recurrent ovarian cancer is a much worse disease because we have much less chance of success. Most of the time we're giving drugs sequentially and single agent rather than combination. There have been some success with some of the biologics and our anti-angiogenesis drugs. And most trials have shown improvement in progression-free survival, but none in overall survival to date. If you look at the NCCN compendium, there's a whole laundry list there of drugs that sort of is purposely small and blurry. You know, so it's have to pick out what do you think is going to work. And then this is the most discouraging thing, is that it's all about 20%. So when we talk about, you know, there's nothing, you know, we have our list of drugs. If you went, when I was in Minnesota, at the University of Minnesota, you know, we would sometimes collaborate with the Mayo Clinic. And if you had recurrent ovarian cancer at the Mayo Clinic, you would get topotecan, gemcitabine, Taxol, etoposide, hospice. That was sort of their regimen. You would run through those 4. And you can see why that the order is pretty arbitrary in the sense that they're all about a 20% response rate for any single agent. So for the longest time, it's sort of a very discouraging scenario when you have a patient who's platinum resistant and you sort of pick a drug based upon its side effect profile, based upon its ease of administration, knowing that efficacy-wise, our chance of response is low. This is the first study that actually showed a benefit to combined therapy for patients with recurrent ovarian cancer that is platinum resistant, and it looked at chemotherapy or chemotherapy plus Avastin, which is an angiogenesis inhibitor, VEGF, so prevents growth of new blood vessels. And what we can see here is that you have better response rates when you have the Avastin or bevacizumab added into the regimen. And then you also end up with better progression-free survival, that top line there. We go from 3.4 months to 6.7. So that's a meaningful benefit for our patients, and we achieve that without a lot of significant toxicity. So again, this study is not important necessarily in terms of the precise logistics of drugs and regimens, but is to show that this is the first time the needle was actually moved for patients with platinum-resistant disease, favoring a combination therapy and improving our response rates compared to that 20%. So it's a slow but incremental progress that we've achieved there. Overall survival has not been improved, but that's also because so many things happen to these patients after the trial that it's hard to impact overall survival, and many of them go on to then receive Avastin. And that's why progression-free survival right now is sort of our standard. What do we use for assessing patients? Because of that study, however, the National Cancer Institute put out on their website about the FDA approval for Avastin with recurrent ovarian cancer. So that was a big deal to have the FDA actually approve it, because that means insurers now have to pay for it, and it's not an off-label use. The next thing I'll talk about will be PARP inhibitors. And this was actually patients with germline mutations of BRCA. So in terms of our pretest question, right now they're approved for patients with a BRCA mutation. And this was solid tumors. So you could have had prostate, breast, pancreatic cancer, and you had to have a solid tumor recurrent disease with a BRCA mutation. When they look at just the ovarian cancer patients who are taking this, the tumor response rate, if you look at CRs, PRs, you end up with about 30%, summing those all together, and you also get stability at 40%. Stable disease, whenever we give chemotherapy, complete response is the best outcome, but in recurrent disease, that's not a realistic expectation most of the time. Partial response can be beneficial. Stability, I often tell my patients, can be a good outcome. If I can achieve stability with an oral agent that you take that doesn't cause nausea or vomiting, doesn't make you ill, maintains your quality of life, that can be a good outcome, and that can be maintained for a time. So when we look at some of these studies and you see stable disease achieved, that's actually can be beneficial. But you could see in this study that the PARP inhibitor had a 34% response rate for patients. And so, and a median duration of response for almost 8 months. So again, a significant, small, but significant incremental progress. Because of this study and several others done, olaparib is actually approved to treat women with recurrent ovarian cancer who have a germline BRCA mutation. So, we're seeing some incremental progress, with the disease. We're seeing new drugs come on board that we're showing improvements in our progression-free survivals. We're showing improvements in our response rates. And we're doing these studies with the idea of we have to make sure we're maintaining quality of life. We have to make sure we're being careful about toxicity and side effects for our patients. I purposely put this slide up there because it's confusing, and it's this is how my head starts to swirl whenever immunotherapy comes up. Immunotherapy is sort of a big buzzword, and it's hard to know what that means. And there's a couple different things. In general, we can break immunotherapy down into 2 broad types. There can be cell-based immunotherapy, often vaccine-based, and there's 20 different ways people do their vaccines, which I'm not going to discuss today because that's more institutional-based, much more, we closed a study for an Ovax vaccine at CTCA just after I got there where we enrolled, and we're waiting to see our response rates and how our patients have done. So those data are being analyzed. But the problem with vaccine studies right now is that most require tissue, and most require going to the center where the technology is, because each center has its own technology. So if patients wanted to participate on our vaccine trial when it was open, they had to come to our center, they had to have surgery to get tissue. So the vaccine ones are very labor intensive and not easily reproduced. So I'm going to focus instead on the drug-based immunotherapy, which is where there's been a lot of press with lung cancer and melanoma lately, but we're also starting to study this for patients with ovarian cancer. In terms of the two classes, it relates to what we call checkpoint inhibitors. So there's a class for anti-CTLA-4 antibodies, and if you look at that little diagram below in the first panel A there, CTLA-4, it's upregulated when naive T cells are stimulated. So after it gets upregulated with the stimulation of the cell, receptor gets expressed, it binds to B7, which then leads to T cell inactivation, and that's sort of a normal homeostatic mechanism. What we can find, though, is that if we can block that B7 with the antibody to CTLA-4, we can actually have increased immune response. And what we can see is that what this allows the T cells to do is it allows the T cells to not only stay activated, but they can infiltrate local tumors. One of the problems is that local tumors will often downregulate T cells. And we know from data done at University of Pennsylvania when I was a student at the time that patients whose tumors are infiltrated with T cells do better. And that's partly because the T cells will lead to apoptosis and cell death. So if we can prevent the T cells from being deactivated by blocking this receptor, we can potentially lead to an immunologic response in the patients. And then there's also PD-1 antibodies. If you look at this one, so PD-1 really works in the periphery. It works multiple points in the immune system, but this one's in the periphery where when it binds to its ligand PD-L1, it's downregulated. Well, a lot of ovarian cancer cells actually express PD-L1. So if the cancer expresses that and the T cell comes to the tumor's microenvironment, it'll be downregulated potentially. So if we can block that downregulation either with a conjugate monoclonal antibody to PD-1 or to the PD-L1 ligand, we can potentially prevent the T cells from being deactivated in the tumor microenvironment, and then the T cells can then lead to an immune response, which leads to cellular death. So these are some, very exciting times, I think, in terms of cancer therapy, where we can use the immune system to achieve sort of an excellent response to a tumor without a lot of toxicity to a patient. For some of the common side effects are autoimmune related, as one would expect, thyroid disorders, pneumonitis. But there are not typically severe side effects. So this is where we're starting to see some promise. This is just a list of some of the drugs there. So the anti-CTLA-4 antibodies, ipilimumab, tremelimumab, on an unpronounceable umab. So I have a hard time with all these. They are such tongue twisters, and there's a new one every week. We are actually studying pembrolizumab for patients with recurrent ovarian cancer, which is an anti-PD-1 antibody. This is sort of the next phase of where things are going. And, we've sort of laid a foundation with chemotherapy, platinum-based and intraperitoneal chemotherapy for the centers that do it. We've seen improvements in our patients' outcomes when we add in anti-angiogenic therapy, and now this next wave is immunotherapy, which I think is going to be very promising for our patients with ovarian cancer and other advanced diseases that are typically very tough to treat. I'll next give a brief clinical vignette while we talk about personalized cancer care. This is also something that we see in the news. We see every center, advertising it in terms of, and what does that mean for the patient? And so I'll present a 36-year-old woman who came to my practice in 2013. She had a recurrent clear cell ovarian cancer. Clear cell cancers are historically chemotherapy resistant. She had surgery, she had chemotherapy, and then she recurred. She recurred in the pelvis, had a left colon resection, had radiation. She had a recurrence in the liver. She had a liver resection. She was treated with an aromatase inhibitor because her tumor expressed estrogen receptors, so a very common strategy used for these types of cancers. She had another recurrence and another liver resection. She had a fourth recurrence in her liver, was not deemed to be operable, and was advised to stop therapy at that point. 2 young daughters. And she came to us. So this was her scan in 2013, and you could see on her PET scan there 2 areas in the liver. That brighter one that's more medial and central is sort of right over the central vessels and cava. That was in the surgical bed where she had just had her last resection, so there was no way we were going to touch her surgically based upon that. We started treatment with chemotherapy. We added in the anti-angiogenic agent, knowing that we tend to see improved response. And she started to show benefit. And you could see there that one lesion that was in the front is really not there as much anymore. She still had residual disease in that old surgical bed, so we treated that with localized radiation. We still had some disease, and she was now at this point, had been on chemotherapy for several months. And she was doing a weekly regimen with the gemcitabine coming up from Baltimore to our center. That gets old quick, especially when you have 2 young kids at home. And when I started with her, she was still homeschooling her 2 daughters. So she was doing a lot. So quality of life, maintaining her quality of life was important because I had to be very judicious about if I give her treatment that puts her in bed and she can't be part of her children's lives, I'm not doing her a favor. We actually did next generation sequencing of her tumor and identified a mutation where an mTOR inhibitor, more typically used in kidney cancer, would potentially be active. And we started her on that therapy in 2014, and at our follow-up scans, she's been disease-free now. She's actually going to be 2 years this coming July, provided she continues to do well. Obviously, it's not the usual case, but I think it gives us an insight into one of the things we're starting to do more and more of is when we have our patients who have a resistant cancer or a cancer that's failed conventional therapies, is we can do next generation sequencing, we can do immunohistochemistry to find out what mutations does the cancer have that might be drivers of its biology. We can test for 600 mutations. The problem is there's only about 10 that are really actionable. And the other problem is we don't know which ones are really driving the biology of the disease. So we're still shooting from the hip a little bit. But what this can often do is if we can identify mutations specific to this patient's cancer, that allows us to think about other therapies that I wouldn't have thought of giving her an mTOR inhibitor, Afinitor, at that point in time. It's just not on anyone's radar to use that drug for an ovarian cancer unless we do some additional testing. And I think that's one of the sort of benefits when we talk about what we're talking about with personalized cancer therapy. It's trying to find out, what drives this cancer's behavior. Some proponents are actually pushing for, it's not so much where the cancer started, it's what mutations does it have. And the extremists will talk about, we don't talk about prostate anymore, we talk about cancers with PIK3CA mutations, and we talk about cancers with BRCA mutations, and we talk about cancers, with RAD51 mutations. We don't talk about where it came from, we talk about its genetics, which is very different than if we think about, where we start with pathology under the microscope. Because under the microscope, every serous ovarian cancer is going to look alike. My prostate cancer is going to look just like the next person's. But if the cancer is due to a mutation in our DNA, and my DNA is different than your DNA, there's a chance my cancer may have different mutations and different drivers. And so that's also an exciting frontier. I call that a frontier because there's still a lot of work to be done to figure out what works, what doesn't, how do we identify the most appropriate patients. In many ways, this example that I presented, part of it, we were lucky. She responded. But we think about ovarian cancer and its natural history. Typically, a patient will go from diagnosis and achieve a remission, but then have a first recurrence. She'll then have a second recurrence at a shorter interval, a third recurrence, assuming she achieves another complete response. It's a big assumption. But then what happens is that we start to end up lower down the line, where the recurrences get shorter, and then we end up sort of on this downward trajectory where we're just treating sequentially treatment after treatment until we either get a response, which we know is not often likely, or we start to reach undue toxicity to the patient where performance status is not going to allow further therapy. And so if we can alter that natural history of the disease, we can really benefit our patients. And that's sort of what we've seen there with that case example provided. End with a quote from Lord Kelvin, since we used him when we talked about quality and measuring. That went very quickly, and that's like 60-some slides there. So hey, I don't think anyone's going to complain if I conclude early. Thank you.